Hi everybody. Today I am going to talk on pharmacodynamics. So what is pharmacodynamics? Pharmacodynamics, the effect of drugs on the human body. Simply, pharmacodynamics is the study of mechanism of action of drugs. It involves the biochemical, cellular and physiological effects of the drug. Most of the drug they interact with their specific receptors are drug targets on the cells. So what are receptors? Receptors are regulatory proteins with high selectivity and affinity for the drugs. Now all the drugs do not do not act through the receptors, but some of the drugs or several drugs, they also act by combining with certain enzymes and transport proteins. Now we will see some of the terms which are used in context with the receptors. Agonists, antagonists. So what are agonists? Agonists are the drugs which activate the receptors to signal for the change and produce the effect. So in simple terms, these drugs, they combine with the receptor, they activate the receptor and they produce the effect. Whereas antagonists, they bind to the receptor, but they do not activate any change. So they do not produce any effect. In fact, antagonists, they interfere with the binding of agonist with the receptor, and so they block their effect. And we often call antagonists as blockers. Now, these antagonists could be like H2 receptor antagonist, ranitidine, beta-2 agonist like metoprolol, atenolol, and so many others. Now, in the antagonist, there are two types which are there. One is called competitive antagonist, another is called non-competitive antagonist. Now, the competitive antagonist means that the antagonist has high affinity for the same receptor to that of agonist. So both agonist and antagonist, they bind with the same receptor at the same site. And antagonist has high affinity than agonist. So competitive antagonist, they block the effect of agonist. It could be in a reversible manner or it could be in irreversible manner. Now, reversible antagonists, they have a weak binding with the receptor, whereas irreversible antagonists, they have a strong binding, like covalent binding with the receptors. Naloxone and morphine, just for an example, naloxone is an antagonist to morphine receptor or mu receptors, and this is a competitive antagonist, which is reversible. Whereas phenoxybenzoamine, which is an alpha-1 blocker or alpha-1 receptor antagonist, it is an irreversible antagonist. Now, another type of antagonist is non-competitive, and these non-competitive antagonists are mostly irreversible type of antagonist. Now, in this case, the antagonist, it binds to the same receptor to that of agonist, but the site of binding is different. So antagonists bind to the same receptor, but the sites are different. For example, ketamine and memantine, they are non-competitive antagonists of NMDA receptor in the central nervous system. Now then, in the same receptor binding, we have another term which is known as partial agonist. As the name indicates, they are the agonist which combines with the receptor, produce their effect, but the effect is not maximum response. They do not produce the maximum response. So it remains partial. So you can say they produce some maximal response. For example, buprenorphine, which is a morphine or opiate type of drug, it has a partial agonist with mu receptors. Varenicline, which is binding with the central nicotinic receptor, also is a partial agonist, which is used for the treatment of smoking cessation. Now then another term is called inverse agonist. What is inverse agonist? They bind to the receptor, they produce their effect, but these effects are opposite to that of agonist. For example, H1 blocker, antihistamines, are D2 antagonist, and angiotensin 2 receptor blocker, AT1 blocker, what is known as. So inverse agonist, they are the agonist with opposite action. Another important thing which is important to know in pharmacodynamics is the dose response. Now this dose response is graded dose response. In the graded dose response, the response depends on the dose of the drug. As simple as that. So as you increase the dose, the response increases. Now in this graded dose response, there are two terms which are very important to know. One is potency, another is efficacy of the drug. Now the question is, if potency and efficacy are the same? The answer is no. Potency and efficacy, they are two different terms. Potency is related to the drug dose, whereas efficacy is related to clinical benefits, or total effect of the drug. So what is potency? Potency is the function of dose. Lower the dose, higher the potency. If the dose is very low, we say the drug is highly potent. If the dose is very high, we say the drug is less potent. Whereas efficacy is talking only about clinical benefits, irrespective of the dose. So in clinical practice, the doctors are concerned with the efficacy of the drug, not the potency of the drug in real sense. Because doctors are not worried or concerned about the quantity of the drug used or the potency of the drug used. They are more concerned about the overall efficacy of the drug. A highly potent drug may be less effective than the less potent drug, which can be highly effective. Now if we see this picture, we can see there are two drugs, X and Y, and drug X and Y has the same effect as the graph indicates. But drug X is requiring lesser dose than drug Y to produce the same effect. So we say that drug X is more potent than drug Y, and both have got the equal maximum effect. Whereas in the next case, drug X and Y, there is a difference in the efficacy of the drug. The drug X is more effective than drug Y. So we should be very much clear about the potency and efficacy of the drug. Then another dose effect or dose response, which you can find in the drug context, is quantal dose response or quantal dose effect. So quantal means either or, means there are certain events or there are several events where you cannot measure the response in a proportional manner, but you require the numbers. So they are either all or none, like seizures, arrhythmias, or death. So for such kind of events or such kind of response, the parameter used are median effective dose, ED50, the median lethal dose, which is for toxicity, that is called LD50, and the therapeutic index is the ratio of LD50 upon ED50. So what is this 50 in ED50 and LD50? So when we say ED50, it means the median effective dose, which is effective in 50% of the population, or the effective dose which is the dose which is effective in 50% of the population. Similarly, when we say lethal dose, it indicates the dose which is lethal in 50% of the population. Now, in human beings, we can't assess the lethality of response. We can't go to the level of lethal dose. So mostly this term is applicable for the animal studies or animal toxicity studies. However, the connotation is that the therapeutic index, which is the ratio of LD50 and ED50, it indicates the safety margin of the drug. Higher the ratio, higher the index, the better is the case. So means we want a drug with a high LD50 and low ED50. So margin of safety is wider. Now we come to desensitization of receptors. What is desensitization of receptors? Which is also known as downregulation of receptors. Now this is a very interesting phenomenon where the drug receptor, if the receptor is exposed to the drug or agonist for a prolonged period, or if there is continuous exposure of agonist to the receptor becomes desensitized. It becomes hypoactive, or it is less activated, causing drug tolerance, which is commonly seen in the drugs of central nervous system like tranquilizers, sedatives, and morphine, etc. But sometimes this desensitization of receptor has got a beneficial therapeutic effect. Take the example of leuprolide, which is a gonadotropin releasing hormone analog acting on the receptor of GnRH. The continuous use of leuprolide or regular use of leuprolide, it causes desensitization of GnRH receptor, causing reduced release or reduced secretion or release of androgens that is useful in the treatment of prostate cancer. So when you give GnRH analog in the initial phase to the patient, there may be an increase of androgen because the receptors are activated, but after chronic use of these drugs, the receptors are downregulated and the same drug produce lesser androgen, which is finding usefulness in the treatment of prostate cancer. Opposite to the phenomena of desensitization, there is a term called receptor supersensitivity. It is just opposite to what we have just discussed. In this case, if the receptor is not exposed to agonist, or it is devoid of agonist, or it is chronically exposed to an antagonist, in that case, the receptor become more sensitive to the drug. Now, in this case, if you suddenly withdraw the drug, in that case, there could be a rebound effect. Take the example of beta blockers, which are antagonists. They are used for various cardiac problems, various kind of heart diseases. If the patient is taking beta blocker for a long time, the receptor, due to beta blocking effect, chronically becomes supersensitive. So if you suddenly withdraw beta blocker, these receptors, which are hypersensitive, they are acted upon by the sympathetic neurotransmitter adrenaline, causing rebound tachycardia and angina symptoms. On the same line, there is a phenomenon called denervation supersensitivity. In this case, if a skeletal muscle, if it is denervated, the stimulation of that skeletal muscle to acetylcholine is higher as compared to a normal muscle. Because this denervation causes more number of nicotinic receptors to be formed at the motor end plate of the muscles. So it indicates that once the receptors are devoid of the neurotransmitter or they are devoid of agonist for a long time, they become supersensitive and they show a rebound phenomena or supersensitivity phenomena. Then another thing which is very often seen in some of the CNS drugs and few others is the phenomena of tolerance. The tolerance is again, as we have just seen, if the drug is given chronically for a long time, the response may reduce, which is often seen with opiates and other CNS drugs. Amphetamine, which is a drug used for causing anorexia, also shows high degree of tolerance. Sometimes this tolerance can be beneficial, especially if it is for any side effect. Say the example of beta-T agonist like salbutamol in patients with asthma. When these patients start taking this drug in the initial phase, they develop side effect tremors sometime or in some of the patients. But as they continue to take this medicine, this side effect of tremor vanishes because there is a tolerance to the side effect of tremor by beta 2 agonist. So it is a beneficial side effect, you can say. Tachyphylaxis is a tolerance, but the difference is it is acute tolerance. It develops after rapid and short-term use of the drug. In the tolerance, what we have seen that it develops after long-term use of the drug, whereas in tachyphylaxis, it develops after short-term use of the drug. The drugs which shows the phenomena of tachyphylaxis are like psychedelics, LSD, opiates, salbutamol, nicotine, nitroglycerin, and intranasal decongestant. So it is very, very important for the physician to know the phenomena of tachyphylaxis, especially, say, for example, if there is a use of nitroglycerin for angina or use of decongestant for rhinitis, etc., because patient may keep on taking this medicine quite frequently if he is not told about this particular phenomena. Because the drug, immediately the drug is taken, and after 1 or 2 doses, the patient does not find any response and he keep on repeating the dose of the same drug, which can be disastrous. Then there is a phenomenon called physiological antagonism, where there is no involvement of receptor. This antagonism is purely between 2 drugs having opposite effects, and this is a physiological antagonism. Say protamine antagonizes heparin. Now heparin is an anticoagulant, and sometimes in the overdose of heparin there is a risk of bleeding or there is a bleeding. So to antagonize the effect, there is an antidote which is called protamine, which is given just to neutralize the drug. And it is purely an acid-basic neutralization. Protamine is basic and heparin is acidic in nature. Similarly, the corticosteroids, which have the tendency to cause hyperglycemia, this effect can be antagonized by insulin. Now these 2 drugs, corticosteroid and insulin, they have opposite effect on blood sugar level. Like drug antagonism, there is another phenomenon which is called drug synergism, where the 2 drugs are complementary to each other. There is an addition to the effect, the mechanism of action. There are 2 different mechanisms of action to achieve the higher therapeutic response. And drug synergism help to reduce the side effects also, because the dose required for 2 drugs given together is lesser than the individual drugs. In the treatment of hypertension, say use of 2 or 3 antihypertensive drugs, or in diabetes, the use of 2 or 3 antidiabetic drugs. These are the examples of drug synergism. Now this drug synergism could be a simple additive effect, where the drug combination produces effect which is sum of the effect of individual drugs. That is 1 + 1 is equal to 2. Or the other case, it could be potentiation, where the drug combination has got more effect than the sum of the individual drugs. That is 1 + 1 is more than 2. The example is sulfamethoxazole and trimethoprim. Both are antibacterial, but when they are given together, their effect, combined effect of these 2 is much, much more than the individual effects. The idiosyncratic reaction is an abnormal reactivity to the drug that is peculiar to an individual. It is not seen in masses. It is a very peculiar phenomena which is not explained why it can happen, but it is sometimes seen that certain people are highly sensitive to a very low dose of the drug, and certain people are absolutely insensitive to the higher dose of the drug. Such kind of abnormal reaction or abnormal behavior of the drug is known as idiosyncratic reaction, and it is said that probably it is due to the drug binding to the serum proteins, which leads to immunotoxicological response. Now, at the later part of the discussion, we have a point on PK/PD. PK/PD is pharmacokinetics, pharmacodynamics. These 2 are important, or they are correlated, because they decide the dose-effect relationship. And in fact, PK/PD is the scientific basis of modern therapy or modern therapeutics. PK deals with the dose and concentration, and PD deals with the concentration and effect. So dose is important, the concentration is important, and the effect is important. So PK-PD deals with the magnitude of effect, therapeutic concentration as well as toxic concentration. So the knowledge of both PK-PD together is very, very important, and that is why there is a PK-PD modeling by various techniques and methods which are done in drug development, and also PK-PD modeling is applied in applied therapeutics. We have seen in previous slides our earlier discussions in variability and drug response. Just to have a quick look on that, the drug response are variable depending on multiple things. One is ethnicity, as you see that the combination of hydrazine and ISDN, which is isosorbide dinitrate, in African American is very, very effective in the treatment of heart failure, but in other races or other ethnic population, it is not so much effective. Similarly, Japanese are having more effect with gefitinib, which is an anti-cancer drug, than any other population. There could be other variability, there could be other factors which can show the variability in drug response, like age, pregnancy, disease, drug interactions, and genetic variability. We have already discussed in pharmacodynamics in previous discussions. Age is important because greater and prolonged effect at the extreme of age due to reduced GFR. Age decides the clearance of the drug, and as you know that in the extremes of ages, if the too early, too young infants, children are too elderly patient, they may have reduced GFR, and accordingly they may show a different response. If you take the example of gentamicin, the half-life is 18 hours in premature infants, it is 10 hours in term babies, and it is 1 to 4 hours in normal adults. So you will find a different dose and different response and different profile of toxicity in depending on the age groups. Also, the age decides the volume of distribution. Like in elderly population, because of high fat mass, there could be accumulation of lipophilic drug like benzodiazepines, and because of this drug accumulation, they are more liable to develop side effects of benzodiazepines. You will find a lot of elderlies, they have confusion as one of the common side effects than proper sedation with benzodiazepines. So this is important to know while prescribing these medicines. Similarly, antihypertensive tend to produce postural hypertension in elderly population. Pregnancy is another factor or another physiological condition where the drug response could be variable because it affects the drug disposition both in mother and the fetus. There is a decrease in plasma albumin, there is an increase in cardiac output, there is increased GFR and drug elimination during pregnancy. And we had discussed that lipid-soluble drug crosses the placenta and they may affect the fetal health. The coexisting illness, they modify the pharmacokinetics and pharmacodynamics of the drug. If there is a kidney dysfunction, there is a liver dysfunction, all this can affect the pharmacokinetics and accordingly the response. The delayed absorption or delayed drug absorption is seen in migraine and diabetic neuropathy because of slowing of the gastric emptying. And also in conditions like heart failure and nephrotic syndrome, there is an altered absorption because there is an intestinal edema. So coexisting illness. So it is important that when the treatment is prescribed to any patient, it is important to know the history that if he is suffering from any other concomitant illness. The drug interactions, as we had discussed already in the past, but here again just to highlight 2 points, that 20% of adverse drug reaction due to drug interactions, of which 30% are serious. And these interactions could be pharmacodynamic interactions like beta blockers in asthma patients. It is a precaution or almost a contraindications because beta blocker, they worsen the asthma treatment, they shouldn't be used. and this is a kind of a drug. It is important that if a patient of asthma is also a patient of hypertension or having cardiac disease, it is a very, very important to monitor the use of beta blocker in asthmatic patient. Similarly, if the patient is taking a diuretic which is causing potassium loss or causing hypokalemia, in such patients there is a high tendency or high risk of developing digoxin toxicity. Sildenafil, there is Viagra and nitrate combination is well known, because these two combinations, they can cause potential drop in blood pressure or serious drop in blood pressure. They should not be used together. The use of CNS depressants is not advisable together, and patient of hypothyroidism, they show high sensitivity to pethidine, and so the drug should be used with great care. So these kind of a drug interaction are some of the drug interactions which are pharmacokinetic in nature, like tetracycline is not properly absorbed in presence of an antacid or milk. The patient should be given with precaution, or he should be told not to take these things together. If there is a change in the gastric pH, there could be alteration in the absorption, like in aspirin. Aspirin is absorbed being an acidic drug. If the pH is altered, the absorption can be altered. The altered protein binding also can affect the drug response. We had seen aspirin, sulfonylurea, because both these drugs, they bind to the same plasma protein sites, and aspirin displaces the sulfonylurea, leading to high concentration, and maybe there could be a potential risk of hypoglycemia if these two drugs are taken together. And drug interaction could be like enzyme induction and enzyme inhibition. We have discussed in the previous discussions in detail about induction and inhibition. Thank you.